Really, this is a really special day because this is the first time we're doing this, that we're having our seminar broadcast remotely from the CTR. We've sort of been the home base that developed all of this, and who better have do this than the co-director of Biomedical Informatics at the Medical University of South Carolina, who I first got to know when we first went down there. As we were beginning to really work through the process of building the CTR grant. And one of the very first people I met was Jihad. I said, it's going to be great to work with this guy because he brings such a wealth of knowledge about informatics. And in so many ways, South Carolina is really way ahead of us. So it's really a very great pleasure to introduce my good friend Jihad Obeid, the co-director of Biomedical Informatics Center at the Medical University of South Carolina. Jihad, take it away.
Okay, thank you. Thanks, Bill. So as Bill hinted today, we're going to be talking about what we've done here in informatics in South Carolina, and particularly related to the CTSA and the translational research infrastructure, but of course focus only on informatics tools. So please feel free to, if you have questions, let me know. And I have 52 slides, so I'll try to be quick and leave some time for Q&A at the end as well. I'll start by giving you a brief history of what we're doing, how the Informatics Center here evolved at MUSC, and then talk about the project and some research that we're doing in informatics and near future plans that we have. And then I will conclude with what we're doing with workforce development, or what the NIH now calls workforce development, so our part in that, in education. So the Biomedical Informatics Center at MUSC has been here for quite a while now, a couple of years. And we have a bunch of dedicated informatics faculty and staff. And we do a whole bunch of things for research services support, build custom software, and you'll see some of that today, and do third-party application integration, many of the things that Tim is doing over in Delaware. So I'll be showing you some of those tools today. How we're funded is we have diverse funding. A good chunk of it comes from Health Sciences South Carolina. For those of you who are not familiar with Health Sciences South Carolina, it's a collaborative that was established here in the state back in 2006. And it's sort of the brainchild of the original founders, the CEOs of the institutions in South Carolina. Ray Greenberg was one of them before he left MUSC. And the board of Health Sciences South Carolina is made up of the CEOs of the different institutions that you see on the screen here. So basically, it provides a really nice platform for establishing collaborations between all these institutions across the whole state. So another set of funding is from the NIH, including the CTSA, and a good chunk of it is from MUSC as well. There's also this thing called Smart State here in South Carolina, which funds Smart State Centers, they're called. They're money from the state, which is matched from the institution to create different centers. There are 3 Smart State chairs that we have for informatics in different centers, and these are sort of like grants that you apply for and you get, and as I said, matched by your institution. And they're usually collaborative across the multiple institutions in South Carolina. So one of the new centers that we're still recruiting for is one that's dedicated for informatics. So the history of the center is it was created in 2009 as a program. Was there a question? No. it was created as a program when we started our CTSA grant, and it was the center was eventually declared in 2012. We've recruited since then a Chief Research Informatics Information Officer, Dr. Les Leonard, who's also the director of the Biomedical Informatics Center. And since then, we've recruited a lot more faculty than we've had for dedicated to informatics. So as you can see, the staff has grown significantly since we started in 2009. You can see growth with the CTSA funding, and then more with ERA funding, and then a little bit of a decline since the ERA funding ended, while we were recruiting a new director for the informatics program here. And then since then, we have had significant growth in faculty and more staff. So the way we're structured here is we're a distributed organization. We have a project management office based at headquarters in Health Sciences, South Carolina. Most of the informatics staff are here in Charleston. And we have our biggest data center for the statewide projects in Clemson. And we support the institutions across the state. We have also this thing called the light rail, which is a dark fiber that is being used for a fiber optic network that is being used. It's called South Carolina Light Rail. That data is transmitted across South Carolina on. Our portfolio covers a whole bunch of different tools, from IRB systems all the way down to Palmetto Profiles, which is a research networking tool, and a data warehouse, REDCap, I2B2, and SPARC. So I'll start with the stuff that you may be familiar with. Actually, I know you're familiar with because there was an earlier presentation on REDCap from over there. So REDCap, as you know, is a research electronic data capture system. It's a platform that was developed at Vanderbilt with a consortium collaboration, grew astonishingly over the last 10 years. Started about 2004. I was involved in REDCap early on when I was still at Cornell, when we were only 10 institutions, and now it's like over 500 institutions. And at MUSC, REDCap has grown significantly since we started our informatics program here. We now have over 3,000 active users and over 4,000 projects that went into production. And it also includes surveys, and so it covers both surveys and databases. And the different projects cover a whole different set of topics, from research to quality improvement and operational support projects. So the next big project that we have here is the statewide clinical data warehouse, the Health Sciences South Carolina clinical data warehouse. Currently, the data warehouse, this data warehouse is actually in use. It has 3.8 million patients in it across South Carolina from 4 different institutions, it includes a bunch of data marts that I'll show you some examples of, and live and batch feeds from the different institutions. It has its own governance. The governance is based on a data collaboration agreement, and it has a multitude of different work groups and advisory committees, including an honest broker system, and input from the different institutional IRBs. The data collaboration agreement actually is one of the things that we're proud of here in South Carolina. Basically, we had the data collaboration agreement worked out with all the legal departments at all these different institutions. Currently, we have Greenville Health System, MUHA, which is MUSC Health Authority, Palmetto Health, and Spartanburg, also in the upstate. And there are BAAs between HSSC and all these different institutions and Clemson, where the data actually lives. When we first started, we had some vendors working with us who had their own BAAs as well. So the data collaboration agreement was signed early on by the different CEOs of the board members of Health Sciences South Carolina. And it established the foundation of the different collaborations and the governance that I showed you earlier. So here's a rough schematic of how the data flows from the different institutions. It has data coming in from MUSC, Greenville, Palmetto Health, and Spartanburg at this point. More on the way. Health Sciences South Carolina is actually growing. We have a couple of institutions that are coming on board as well. So the data flows from these different systems, either via HL7 feeds or from individual clinical data warehouses batch feeds. And we store all that in the operational data store at Clemson and create a bunch of, then we create an actual STAR schema, a clinical data warehouse schema, from which we create a multitude of data marts for specific projects. One of these data marts is the I2B2, the de-identified I2B2 instance that we are running at Health Sciences South Carolina. So the data warehouse actually includes we had a phased approach to bring in different data elements into the data warehouse. We went live in 2013, mid-2013. We started out with patient demographics and diagnosis and procedures. And since then, we've brought in medications, and very soon in 2015, early 2015, we're bringing in labs. So currently, as I mentioned, we have around 3.9 million patients ranging from 1993 in the statewide system to up to date. And encounters of about 34 million encounters and 99 million diagnoses across these different encounters, procedures, 12 million, medication orders, 10 million, and so on and so forth. So this shows you a rough schematic of how we release data to our users. We have an IRB approved protocol to do this. And actually, we have two different protocols, one that covers MUSC data and one that covers HSSC data. I'm the PI on both protocols, and they are each of them has two different branches. One that allows, basically it's a HIPAA waiver and consent waiver that allows us to expose de-identified aggregate data to the users. And the other branch of it is a mechanism for brokered data access. So if people want more detailed data or identified data, then they have to go through a data request committee and provide a consultation to the data request committee, who then ensures that there is proper regulatory oversight and IRB approval depending on what they're asking for. And then the request is forwarded to the honest broker, who is basically a data warehouse administrator. It can access and do SQL queries on the data warehouse and create a report back to the researchers. The self-service access that I mentioned, so we have two of them, one for Health Sciences South Carolina and one for MUSC. The Health Sciences South Carolina interface is the one I'm going to focus on here. It's an I2B2 interface, and right now, the way we allow users to log in is we use basically the user set that is already in our IRB system. So we allowed all those users click through with a data use agreement, click through access to the I2B2 query interface. When you log into I2B2, you have an option to either look at your institution's data, depending on what institution you're coming from. In our case, we come from MUSC, so we can either see MUSC only data or HSSC-wide aggregate. But I cannot see data from Palmetto Health, for example. And we designed it like this, and this is spelled out in the data collaboration agreement to prevent people from, or to make it harder for people to do competitive queries, queries of a competitive nature. Then we have a separate interface for MUSC data, which uses a typical business intelligence tool. We use MicroStrategy here, but we didn't get good feedback on that, so we're thinking of replacing that with either I2B2 or another interface. To access the HSSC data warehouse, we have a website through HSSC that allows you to access the brokered mechanism as well as the I2B2 login. And we have also through the CTSA website at MUSC, we call our CTSA the South Carolina Clinical and Translational Research Institute, sector for short. So through sector website, you can get to our data warehouse. And from there, you have access to all of these systems, including the MUSC brokered mechanism. We also expose our data dictionaries here. Here's what the I2B2 web client looks like. It's a drag and drop interface that allows you to do some basic Boolean logic, and it also includes some plugins that you can look at, for example, demographic breakdowns and things like that. It also keeps the queries that for each user that they log in, both for auditing purposes and for the users to be able to pull back the queries that they've run before. To request brokered data, you go through our SPARCrequest system, which is actually a system that we're going to show you more in detail in a minute. But in Spark, you can request through sector Biomedical Informatics Services. You will see a MUSC Research Data Warehouse request, and that's how you can get access to the brokered data warehouse services. So I'm going to have Lane next to me. She's our lead analyst on Spark. Talk to you about Spark here and what we're doing with Spark. So Lane.
Can I just sit here?
No, it's better to come here. So you want
Hi, everybody. So I'm Lane Glenn, and as Dr. Bates said, I'm the lead analyst on SPARCrequest. I believe we've talked to you about SPARCrequest before. It is a web-based CTSA research, or CTSI, research management and request tool that also tracks all of our work fulfillment. So all of the metrics that we have to report to the federal government for refunding or for annual progress report comes from SPARCrequest. It's not only for our CTSA services, it is also our enterprise-wide research portal here at MUSC. So we have all of our hospital services, our private physician plan services, anything that you could think of for research, you would come through SPARCrequest to request and get a budget for. Was there a question? Okay. As I just mentioned, there is a budgeting tool, so it's very helpful for clinical trials that are coming through. They can put together their entire protocol and get a direct cost budget. We do have document routing, so we can route documents to specific providers instead of having to send documents through emails. There are user and administrative portals, so each user has their own user portal where they can manage all of their protocols in the portal and all of their service requests and all of their users. And then our administrators or our service providers have a tool where they can go in and indicate how much work they've done on a particular request and process the requests that they've received. As I mentioned, we house pretty much anything you can think of for research, so it's not just clinical services, it's basic science as well. We do have a live Epic interface. I'll show you on the next page, but what might take an analyst in Epic, 5 or 6 hours to build, you can do through SPARCrequest in an average of about 10 minutes. We have auditing and reporting features. We're boosting our reporting features right now and making more of a query tool where you can define the reports that you'd like to see. And then we have a system satisfaction survey built directly into the tool. Right now, with over 12,000 users, we have about a 91% satisfaction rate here at MUSC. As I mentioned, we have an Epic interface. So this is one of the pages in Spark, and this would be specific for a clinical trial. Once you've selected your services, then you can start to get pricing, and you can indicate for each service the source of funding. So is the venipuncture at visit 1 supposed to be billed to the patient's insurance, or is it supposed to be billed to the grant? And this will whittle down and provide for you a specific research grant or research contract budget. This information right here interfaces over to Epic and builds what Epic calls the billing protocol. So essentially, when a physician orders and results a test, the system looks to this information right here and automatically routes charges. So there's no manual picking, this particular charge goes to the grant, this particular charge goes to third-party payer. The system automatically routes charges to the correct hospital account based on what information is needed. Any questions on the Epic interface?
We are really seriously impressed.
It took a long time, but it's we were one of 2 institutions that did this in the country. There are others now, but we were one of the first 2, and it's been a huge time saver for us. So it's kind of amazing when you think about it. See. And then SPARCrequest is an open source tool, so we actively have, I think yesterday I got my 6th institution that will be implementing the software. So all of these schools are at different stages of implementation. Children's National, the first one up there on the left, has implemented, and they've been implemented for almost a year now. So things are going very well. Everybody else is in some phase of implementation, and then I just got one more yesterday. So feel free to visit our website. There's all sorts of recorded trainings. You can sign up for our listserv. We have monthly calls that talk about what new functionality is coming out, what bug fixes we may be pushing up to the open source branch of code. So our next call is Monday, December 15th. And if you visit this website listed here, you can sign up for that listserv. That was a very high-level overview of Spark, and I'm happy to set up some additional time to dive deep into that. But are there any questions that I can answer?
So what are your biggest problems, right? I mean, you've overwhelmed us. What are your biggest problems right now? If we decide to follow you, what are the kind of challenges that we're going to face?
I mean, we had to do a huge culture shift here at MUSC. I mean, the process before Spark was completely paper. I mean, you had to know who to call to get a price. You had to know who to inform when you wanted to order a service. So with the ushering in of Epic, Spark kind of piggybacked on that, and it was a huge culture change. I mean, it was not met with 100% satisfaction by any means, but now that we're kind of underway and we've started using the system, people see the benefits. And like I said, we have a very high satisfaction rate with Spark. We've made our pricing transparent, which we never used to do before. Everybody's getting the same pricing, which again used to be a problem. Some people brokered their own deals. So I think that the main thing that we had to contend with was adoption of the system.
I agree. Adoption is also a problem. I mean, as you know, with so many of the basic science scores are very resistant for some reason to adopt new tools. So adoption, even locally, is a problem. But we're getting better at it.
Yep, we just had 2 more basic science cores come to us and want to put their services in Spark in the last 2 weeks. So people are, the word is catching and spreading across campus and across these different institutions. Any other questions?
Are all your institutions EPIC users?
Some. UCSF is an EPIC user. LA or LaCats will be an EPIC user, but people are doing a phased-in approach. So they're implementing Spark. They're going to, watch it for 3 or 4 months and then implement the EPIC interface. Duke also uses EPIC.
Just to be clear, though, Spark is not necessarily just for EPIC. I mean, as Lane showed you in a previous slide, that it was actually created just for requesting services from across the CTSA cores, and so we could track them and be able to report on them.
Right. EPIC is not a requirement to adopt Spark. We have other, the majority of the institutions that are evaluating Spark do not use EPIC or don't use it yet. Some people do use Cerner, yes. All right, I'll turn it back over to Dr. Obeid.
Thank you, Lane. All right, so one more thing I wanted to mention about Spark is that we're planning to adopt the Bevo ontology, so that you may be familiar with the Bevo ISF ontology and Eagle Eye, which are platforms that allow you to standardize the navigation of different services that are research resources across multiple institutions. So once we do that, it'll be easier to federate queries across multiple institutions as well. So that's eventually where we're going with that. One of the other big systems that we support in our informatics center is the statewide IRB system, EIRB, which is based on CLIC, now Huron. It is on the EIRB system, we have 5 different institutions and 2 more are coming on board, it really provides a nice platform for cooperative review. For example, when I submit my protocols and they go across multiple institutions, I submit my protocol once, and you check the boxes of which other institutions you want, and if they have questions or comments, they ask you what they need. But it's much easier to submit a protocol to one place, and also there's a somewhat of a reliance process. So there is a lead IRB. If a PI is applying from one institution, that would be the lead IRB, and the others would get a more expedited review. And so we've done a lot of work to harmonize the different fields. As you can imagine, different IRBs have different requirements. It's not 100% harmonization, but here in the green, we're showing that the majority of the screens have been harmonized, and there are some certain requirements that are difficult to harmonize across institutions. Related to EIRB, we have this thing called scresearch.org, which is a listing of our clinical studies across South Carolina. And what made this easier to accomplish is that we own the data for the EIRB system. So when somebody is applying for the IRB protocol, they have an option to check a box indicating whether they want their study to be made available to the public for recruitment. And if they do check that, they enter a layperson narrative, and that narrative will show up in a searchable listing on scresearch.org. Research networking tools. I've been talking to Tim about Palmetto Profiles. Research networking tools are, for those of you who are not familiar with them, are tools that allow you to collaborate across to find collaborators. Basically, what you're doing is taking your researchers and putting them into a database so that they're more easily searchable, and they can log in and update their profiles. They can use their pages as their online CVs, and they get better visibility across the web. There are different systems across the country. We did a study early in 2012, and it has progressed a lot since then. But back then, about a quarter of the market was divided into 4 quarters almost. Bevo was one of the biggest adopters, along with Profiles. SciVal Experts, which is a commercial alternative from Elsevier, and a bunch of other homegrown tools out there. So we've at MUSC adopted Palmetto Profiles early on. We actually used to be on Calexis before 2009, which is a precursor to SciVal Experts, but we didn't like that very much. It was a system in transition. We couldn't look at the data. The data was owned by Calexis back then, before it was bought by Elsevier. And it was also an expense. So we went with Palmetto Profiles, which is open source and allowed us to collaborate and do research on the data that we collect in Profiles. And Profiles has some really nice visualization tools, like you can look at your network of co-authors. You can also look at timelines of your mesh terms, your evolution of your career, and so on. The other thing with those tools is that you can expose them to national networks. One example is directtoexperts.org, which is run out of Harvard as well. And we're on that already. So here's an example. So now that we're on version 2 of Palmetto Profiles, it exposes the data in linked open data, which means that it's more available for semantic web searches, and it has a SPARCle endpoint. So it's an open API that people can go in and do queries on the data. So here's an example of queries on mesh terms. Doesn't look very interesting, so we're still playing around with how we can show our data. After removing the biggest mesh terms, then we got a look at other mesh terms. I'm still trying to refine this to show it in a better way. Another thing that you can do is do queries on. So what we're trying to do now is see how the sector and the CTSA has impacted cross department and cross discipline collaboration. So here's a snapshot of the cross departmental collaboration. So, and again, we're still playing with that. This is this diagram was just generated today, so I'm still playing around with that. We're thinking of including something like that in our application. The other new thing about Palmetto Profiles is that in the last month and a half, we've added other institutions across the state. We're doing that in a phased approach as well. We have the School of Medicine at USC starting to get on board with a few people. We also have from Clemson the whole School of Engineering getting on board, and the School of Medicine from Greenville. So now you can actually, if you go in Profiles, there's something that allows you to see the map of your collaborators. This is an example of a person who has a cross-state collaboration in bioengineering. And the limitation of that right now, though, is that Profiles is getting its publication information from PubMed. So we're working on getting our publication data from Scopus or Web of Science so that we can actually enrich the data from those data sources as well. besides the different infrastructure projects that I mentioned earlier, we have some specific projects that are funded, like the P60 project for lupus and rheumatology, Alpha One Foundation funding, and Stroke COBRI funding. So 2 NIH and 1 foundation funding. And the vision for those is similar. It's not exactly like that across the board, but the idea is that we create a research registry that can be used for further data mining and registration of people that enter different protocols, so that they can be accessed and the data can be used for future research projects. And the general concept here is a REDCap for data entry with data input from multiple different sources, to the creation of a data mart, and then the creation of an I2B2, a more enriched I2B2 data mart, much richer in depth in terms of data elements than the one I showed you earlier for the data warehouse. That is specific to the investigators on these different projects. We also have a lot of research projects going on in different areas. One of them is electronic consenting and teleconsent, and that's a topic of its own. I can show you some more about that in a future presentation. Big data projects, you've heard about Lewis Frey's project, which is basically actually, I have a slide on that later. And then we're doing also some research on NLP and machine learning algorithms for phenotyping patients. This is just a snapshot of an electronic consent system that we created with an NIH Go grant back in 2012. And we released the software as open source. We're now playing around with teleconsent using a different platform. And we're also looking into collecting research permissions using EPIC. This is just a snapshot of the teleconsent platform that we're working on right now. And it's an interesting, it's based on a telemedicine, a lightweight telemedicine, open source technology, but it's run through a DocCMe, which is a platform that was founded by one of our new faculty members at MUSC. This is the big data platform, Lewis Frey's and Les Leonard's grant, which is they're working on a system that leverages the Vinci data system at the VA to expose some of the analytics from all this data. I will not dive deep into this. This is really Lewis's project. There are many new projects that we're working on as well. One of the more interesting one, in my view, is the Shrine Federated Network of data. So what Shrine is all about is provides the ability of different institutions to expose EHR data, very limited data, like aggregate numbers only, across multiple institutions. And it's also an open source platform, which was created as one of the National Centers for Biomedical Computing funding mechanisms at Harvard, and released to the research community. It's pretty much the de facto standard now for both exposure of EHR data, which is I2B2, and federating data across multiple institutions. It works like this. Right now, we have a pilot going with our partners in North Carolina. So we're exposing our I2B2 data mart through HSSC, along with Duke, Wake Forest, and UNC, all of whom have created an I2B2 data mart directly from their data warehouse, and plugged on top of it and a Shrine adapter with the proper firewall restrictions so that they can be accessed across. So you can log in from any of these institutions and the user accounts are controlled by the institutions, and you can access the federated network of clients. The pilot right now only includes, it was created as a proof of concept, but it has real data from stroke diseases across the collaborative. This is an example of a query that returns data on multiple TIA, transient cerebral ischemic attacks, and you can see how it returns data from the multiple institutions. So you see only aggregate data from the different institutions returned, and it's sort of obfuscated statistically so that you can't really do any triangulation to protect identity. Just for it's an extra layer of protection. We're using the PCORINet ontology for that, which is a a precursor to playing in the PCORINet world, and also it's a precursor to the CTSA acts. We actually, this was just announced last month, that we are now in the second wave of the CTSA wide network, and the reason we got in is because of our pilot work with North Carolina. So that was very helpful to us. Other areas we're working on is research services through EPIC. One of the areas we're exploring is best practice advisories and using those, leveraging BPAs for research recruitment. This has been done before. It's really not new, but it's new to us. We're doing some innovative things by including telemedicine with the BPAs so that we can have more active recruitment through this system. This is just a screenshot of a BPA. The other thing that we're doing with EPIC is we're using MyChart to include questionnaires in the future through MyChart. We've already created a link through to scresearch.org, the clinical trials listing in South Carolina from scresearch.org. I'm sorry, from MyChart. NLP capabilities, so we're working on both the statewide level and MUSC with industry partners to create a more refined phenotyping capabilities using NLP and enriching our clinical data warehouse data. This is very early research right now. We're also working on some open source tools for specific projects. And I think finally, I will just show you a little bit what we're doing in terms of education. We started an informatics course for the Masters in Clinical Research back in 2011. So we're in our fourth year of this, fifth year actually of this course, which is an introductory course to research informatics to our clinical researchers. We also are starting a new health informatics program in the College of Health Professions. This is actually not just an informatics center activity. It's actually led by one of our faculty in the College of Health Professions. And we just recruited a new director to start this master's program. But we are participating in course development and the approval by the Commission of Higher Education, which was done 2 years ago. And then we have, the usual training for clinical data warehouse tools, REDCap, and so on. And we do mentor some students in informatics and participate in ethics seminars dedicated for informatics topics. So I'll stop here for Q&A, and or breaks, whatever you like to do.
So I have a question. Thank you, Gia. That was very, very interesting. I have a question related to the data warehouse. Do you have also? I noticed that you had several health systems in your that provide data to the warehouse.
Yeah.
So do you have primary care practices that provide data to the warehouse, or are they all hospital-based?
Yeah, right now they're all hospital-based. That's a very good question. There is another network in the state which we're not very involved in that is doing more private practices. I think it's called the PPRN, or private practice network. So it's not Epicori, sorry, PPRN is Picori, but it's a PBRN. Practice-based network, and it's run. It used to be run by. Actually, it is run by Brent Egan, who was since then recruited to Greenville. We are thinking about integrating some of that data in the clinical data warehouse, but that's very early phases right now of discussions.
Well, forward.
Yeah.
I'm interested into your bioethics courses that you are offering. Is it specific in informatics and data-related issues?
No, there's just one seminar that I participate in that is dedicated to informatics issues. You know, the things about release of data and when it's controversial to release the data versus not, and things like that. So it's sort of an avant-garde thing here to do from our course director, which is who is Bob Said. He directs the ethics course. So he has multiple different people that participate in this seminar. I mean, in the different seminars. One of them is dedicated to informatics.
Does your IRB collaborative you have go outside the state ever with the CTSR, or just within the state only?
There's only state in our EIRB system. We only have state institutions or institutions within the state. There are protocols, as any other institutions, that are collaborations with other institutions, and like I have a collaboration with UNC. The PI, I'm just the local PI, so that's normal. But we don't have institutions that submit outside South Carolina to the EIRB directly.
That was an excellent presentation. What do you anticipate will be the effect of the finances in terms of the finances of our healthcare system in the United States on what you have put together and how it will proceed in the future?
Thank you. Finances. Well, our finances go up and down. Well, I should say our funding goes up and down with the NIH funding cycles. Sometimes if the NIH funding goes up, our informatics funding goes up. How we can contribute to the finances of healthcare. I mean, our focus is more on research infrastructure rather than healthcare and health information exchanges. So, I mean, it's hard to say at this point how we impact the healthcare expenses long term. So I don't know if that answers your question, but that's a brief answer.
It does, but clearly there's so many things going on in the world of genomics and in the world of detoxification and telehealth and telemedicine and things of that nature that questions are being constantly asked as to whether or not these are going to make our process more or less efficient. And therefore, this wonderful system that you've put together to do research may help answer some of those questions.
That's a very good question. In fact, many of the systems that we design, we actually try to do research on them. Like one example is the electronic consent system. We've collaborated with Clemson, for example, to look at the impact of users, but also we have now a study with, we submitted for a grant which wasn't funded, but to look at the impact long-term on recruitment and, cost savings long-term. But so it's areas that are research that's in the back of our minds, and I think all of these tools have to really prove themselves. So.
Thank you very much.
You mentioned a health information network. Do you have a health information network in South Carolina?
HIE. We have a couple of quasi-HIEs. There's one called SkyX across the, I don't think they're as elaborate as what you have in Delaware, but SkyX collects data from multiple institutions in the Low Country, which is in the Charleston area and the upstate, so it's a little and allows people to look at records briefly across institutions. And then there's also in the Low Country, in the Charleston area and on the coastal areas, something called CHA, or Carolina eHealth Alliance, which is a local HIE that allows only emergency departments look at data across institutions, and the data is stored on blade servers only temporarily, that allows ED physicians to look at data for people who are coming in. But that's a good example of a system that still needs to be evaluated. There aren't, the adoption is not as high as you think. So the system is out there and made available to ED physicians, but not many ED physicians use it. So, but some do. And so now we're looking at ways of how we can prove that it's improved health in the Low Country.
And is there a plan of integrating this data into your warehouse?
It's funny you ask. It's a big political quagmire, but yes, we are working on that.
For us, yes.
And Les Leonard, our CRIO, is working really hard. He's negotiating with our CEO and HSSC board, the HSSC board as a whole. In the last board meeting that we had, everyone was very positive about the idea. So I think it's going to go ahead, but it is a political. It's difficult to actually accomplish. It's not easy.
I understand. Here's a question. Right.
It took us a long time. Sure. Yeah, I just wanted to say that it took us a long time to get the DCA, the Data Collaboration Agreement, just for the HSSC. I mean, we started working on the data, those agreements since Ian was here back in 2009, and we only got that, we're able to expose the data in 2013. So it took a long time. So I suspect, see how, that Carolina eHealth Alliance will take somewhere in maybe 2 years or something to get on board. Yeah, thank you.
Thank you. Thank you.